Thanks very much. Thank you very much for the opportunity. I think it's a great session and it's a privilege to be a part of it. This was a collaborative effort between the universities of Cape Town and Dalhousie University. As we don't have any disclosures, I thought for 7 seconds I'll give you a picture of Cape Town. Maybe not all of the audience is familiar with the city. It's the setting for our study at the tip of Africa. It's a beautiful setting. Groote Hospital is at the base of that's Table Mountain. Tertiary referral hospital, initially made famous by the first cardiac transplant. So there is currently no consensus on how to accurately predict early rebleeding and death after a major variceal bleed. We're very familiar with the Child-Pugh score as well as MELD scores. Child-Pugh was initially described by Child and Turcotte, specifically looking at portocaval shunt surgery, and that was in the late 60s. It was then modified by Pugh et al. In the 70s for looking at outcomes with regards to esophageal resection following bleeding varices. So it's been over almost 50 years since we've looked at the score and revised it. And MELD, it was in the late 90s when that was first described, specifically in the setting of TIPS. So what we proposed was a 4-category recalibration of the Child-Pugh score, or at least look at it again, because it has been up to 50 years with new cutoff values. So just to remind you, the Child-Pugh score is based on these variables, ascites and encephalopathy representing a degree of cirrhosis, and then the synthetic function, albumin, bilirubin, and prothrombin time. It's up to 15 points and divided by the original score is 3 groups with those pointers. And we proposed a recalibration of the score with new cutoff variables. 5, 6, 7 is 8, 9, and 10. And then specifically where we were interested, we thought that perhaps with advances in the way we treat our patients, we're losing granularity in the class C, and therefore introduced a further class D for 14 and 15. So how did this do? How did we test our new recalibrated score? It was a prospective cohort study. All the patients admitted to Groote and managed endoscopically for proven esophageal varices bleeding. Secondly, specifically to alcoholic liver cirrhosis. We made sure of the homogeneity of our cohort, excluding any patients that weren't secondary to alcoholic cirrhosis. It was a long study over 2000 to 2017, so 17 years. On admission, the scores were calculated, and their predictive ability in terms of discriminating in-hospital rebleeding and death were compared. So our outcome variables were rebleeding and death, and compared under the receiver operating characteristic curves. So our results, it was a 288-month study. 403 consecutive patients were referred to us for treating bleeding esophageal varices. 225 of these were secondary to alcoholic cirrhosis. We performed 261 therapeutic endoscopies. In terms of our outcome variables, we had 13% or 31 patients who rebled, and unfortunately we lost 18.7% of our cohort. This is an important slide just to demonstrate initially the Child-Pugh score. Apologies if these figures are small. But what I can point out is in terms of your N, your second column, there's quite a good distribution of patients presenting to our institution amongst every score value. Therefore, it's suggesting you should expand the group. In the first column, rebleeding, the percentages initially, there's a stepwise increase, 6.1, 12 to 36% in the rebleeding groups. And then in our recalibrated, we didn't lose that stepwise increase, and particularly in the group C, 16%, similar to the original group C, but an increase in group D of 18%. With regards to death, Importantly, the Group A, 0 mortality in the original score, and similarly in our Group A, 0 mortality, which is an important finding. And you see increased stepwise mortality both in the original as well as in the recalibrated score. But I can turn your attention to comparing the original Group C to the recalibrated Group C. The original is 33% mortality, recalibrated 32%, but importantly a 68% mortality in the recalibrated in the Group D. Quickly, in terms of the MELD score, there wasn't really an increased rebleeding in 21 to 23. Thanks very much. That's appreciated. Interestingly, that 23 rebleeding in this group and then down to 14. So there wasn't that stepwise increment in rebleeding, but deaths there was. So how did this do? Unfortunately, our scores, both child Pugh, recalibrated child Pugh, and MELD actually very poorly predict rebleeding. I'm not sure if all of you are familiar with analyzing area under the curve, but essentially this is your reference. So that's 50%. So if your line is on that, that's essentially like flipping a coin. You really can predict its odds. So there's not that much area for any of these three scores. Perhaps MELD showed to the eye a little bit, but this was not significantly, statistically significant. However, when you look at predicting death, you can see that the MELD score is the worst of the discriminatory values. And this is what we're contributing, is this area here. And you can see our recalibrated score of 0.84 relative to the original of 0.76, and that was highly statistically significant. So our discussion points, we thought that the recalibrated score demonstrated a significantly improved ability to predict death, but ultimately was not better in predicting rebleeding, and importantly, none of the three scores were good for rebleeding. It provides a refined stratification of patients in the C category of the original child Pugh, but we need to look for predictors to better predict rebleeding. And that's exactly what we are now doing, looking more at endoscopic findings and bleeding findings, and these are models for rebleeding. It was a retrospective analysis, and importantly, it was over a 26-year period, so perhaps advances in this, but we do believe that we've offered something. So in conclusion, our recalibrated child Pugh score outperforms the original child Pugh grade and MELD score in predicting in-hospital death in patients with bleeding esophageal varices secondary to alcoholic liver cirrhosis. We appreciate the opportunity and welcome questions. Thank you.